Hey guys, I'm Natalie Friels, and this is the HealthTech Hot Seat. Super excited for today's interview again from my live at HIMSS 2026 interview series. Today I'll be talking with Dr. Tauhid Mahmud. He is a family medicine physician and informatics fellow at Stony Brook Medical Center in New York. We are talking today everything from AI, informatics, and of course, as always, patient centered care. It's a great chat, and I hope you enjoy. Without further ado, here's my conversation with my good friend, Dr. Tauhid Mahmud. I'm with Tauhid today. Okay, it's HIMSS 2026. This is the Health Tech Hot Seat. Thanks so much for being here.
My pleasure.
Have you enjoyed it?
It has been so much fun. It's very different from the conferences that I think we used to go to, like the academic ones. Very, very different, but still a lot of fun.
All right, so you recently on your LinkedIn called out a job ad. You had like a number of patients that were like unmanageable. So meanwhile, while we're down in the expo, half of the AI demos are telling us how they can make us work faster so we can see more patients. What is the answer?
Isn't that crazy? So I think everyone is thinking about different things, right? If you are an AI company or you are a health system that invested in an AI company, you're just like, okay, this is very expensive, but everyone's talking about it. If we purchase it, how do we get some return? There are some soft returns. So for example, let's talk about AI scribes in general. A family physician who's never used one and then tried it out and they like it, it's going to be very difficult to kind of take it back. They absolutely love it, right? So that's been my experience. It's been the experience of my colleagues, and they love AI scribes. But does it actually save time? Well, maybe 5 minutes or so, but maybe if you add them all together, it ends up being an actual additional encounter. It ends up being 60 minutes at the end of the day. Does that mean that 60 minutes is enough to put another patient in? If you're a health system, you're like, if I can squeeze another patient in, that means more revenue and more of a justification for that huge AI investment that we made. But if you're a physician, you're just like, hey, I just was able to get a time to eat my lunch that's been cold for the last 4 hours. I can have a snack before I go home. But it's an interesting conversation. There has to be some way to kind of meet these problems. But at the heart of it is that there's a systemic issue. And AI doesn't solve systemic issues. They make things a little bit better, a little bit nicer, but these things need a policy level solutions.
So how do we solve the systemic issues that we're facing as clinicians, as physicians and non-physician providers?
Do you want
I want
the real truth?
The real
Okay,
truth.
gotcha. So I think I'll speak from primary care because that's been my experience. I think right now we're looking at a few different revenue models. So value-based care was supposed to be the thing. Right? It's supposed to be the thing about 10 years ago, and it still hasn't really sunk in. But I think there's been a renewed interest in this space. Prevention and primary care done right with outcomes being rewarded, not just output. That is a great way to reimburse physicians and physicians doing good quality care. That's one option. The other option is a very exciting new model called DPC. Right? So if there is some sort of subscription model that you're willing to pay, it feels a little bit more justifiable for the physician to actually read a message in the middle of the night or answer questions in the evening and going like, hey, my patients are paying for this service. Whereas if it's a fee-for-service kind of system, you're expected to answer regardless and you're not being compensated for it.
Yeah. Okay. So we're seeing a lot out on LinkedIn or just on other forums of people kind of transitioning to these models, and it actually increasing access for maybe people who we've thought that those models wouldn't serve as well, right? So like even DPC models, we were seeing people either do pricing that's more inclusive or whatever, kind of a conglomerate of various structures. So taking that into account, the need for policy, you are a internal medicine, trained physician, family medicine trained phician,
and preventive
medicine. What do you not do?
Hospital medicine.
Oh, there you go.
Yeah.
Yes. Much to my chagrin. But not only that, but you're also an informaticist. So if we kind of put both of those hats on, thinking about getting patients better care that we all can afford, that the system can afford, what is the next in health tech when we think from like an informatics lens and a family medicine lens?
So that is such an interesting question. And I think there are different ways to kind of address it. The way that we're trying to figure it out at Stony Brook specifically, the things that I've been dabbling in.
Hashtag plug for Stony Brook.
There you go. Come on over.
Come
It's
on.
great. No, it's been a wonderful opportunity for me. So I'm currently in an informatics fellowship, and when I tell people that, they're like, "What is that?" And it's not because they don't know what informatics is, but because the breadth and depth of informatics is huge. Right? It can be just about anything. My specific niche is a little bit on how do you make primary care profitable or at least sustainable. Right? And those are some questions that we're trying to kind of decipher and explain at Stony Brook. And one of the ways that we're thinking about doing that is, well, we do really good care, right? There's a lot of metrics that we hit, but are we providing those metrics in a consistent and clear way to be reimbursed? So there's a pie of revenue, a revenue pie, right? Are we making sure that we're doing our best to say, hey, this is Stony Brook Healthcare, and this is the stuff that we're doing, and we're doing it pretty well. Is that going to payers in an appropriate way? There's a couple of ways to do that, which is we are a Cerner system, making sure our data goes from our EMR into a data warehouse that is actually actionable, and you can send it out to payers. So it's not as like hot as AI, but these are the underlying data pipelines that make up healthcare, and it's really messy. But someone's gotta clean up.
And do you think that the average founder or average founder team knows how messy the data is?
I think that if they did, then they wouldn't make the claims that we hear. Right? So AI is going to solve this. It's going to go through all the charts and it's going to make a summary. It's a lot more messier than that, right? So for example, there is a way to get information about healthcare screening for your patient. So I see a patient, he's a 46-year-old gentleman. They're due for colon cancer screening at 45, right? This is not my patient. I don't know if they've had that screening done. There's a pop-up notification that they need to have it done. The way that it's sometimes documented is that it's in the free text that in a bottom right-hand corner that someone scribbled in, this patient had this screening done at this outside institution. Am I going to be able to pick that up? Absolutely not. Is a AI scribe going to be able to pick that up, or an AI summary tool going to be able to pick that up? Probably. But is that going to then satisfy the EMR? It needs the feedback from the system. So any of these solutions that we're talking about or hearing about, if it's not integrated into the EMR, it's just another product, another thing to click through that just adds more to the burden. And you need a huge engineering team to keep these things running.
And not to mention the cost to the health system. I had a really unfortunate experience with Epic the other day. I want to tell you about it so we can cry together. I had a patient who must have filled out one of those patient questionnaires that gives you every single... So I opened her chart, and I open a lot of charts, and I take care of some sick people. It was the longest medical history I'd ever seen. It was, I counted, it was like over 55 items.
Wow.
Then I looked at her surgical history. It was over 27.
And
I was like, does she have any organs left, first of all? And second of all, this lady is really sick. Well, then I got into it, and I looked, and it was very serious things, every type of hepatitis, HIV, the list went on and on. But then next to everything I saw, next to 95% of the things, a free text of no. So she had accessed some kind of patient reporting, had clicked on all these things and answered no in the free text as a comment. But then it got put in her chart as an actual diagnosis.
Oh my.
And I tell that story because first of all, it's baffling that it happened. But second of all, I love that we're doing more patient facing. And I think also that we have such a great need to understand that workflow even more so. Whoever is changing the data or augmenting the data, because at one point someone said, well, let's send the patients this information. And she knew she didn't have those conditions, but she clicked on them. And so they got to her chart, but it's like, okay, what happened? What went wrong in that scenario?
So many things.
From an informatics standpoint.
But it's a lot of different things. I don't know if it registered the right way, for example. But one thing that I think is critical in your story is that you were there, right? No, you had a clinician that was looking over the chart going like, this doesn't make sense to me. What would an AI have done? It'd been like, oh, these are all the problems.
She has AIDS, HIV,
everything.
And everything.
AIDS and HIV at the same time.
Yeah.
See, it's absurd.
Hyper and hypothyroidism. Yeah.
Why not, right? Yeah.
Yeah.
So anyway, this is why it's not just a hot phrase to say clinician in the loop, right?
Yeah.
It's these kinds of reasons why AI is super awesome when it works well, but these cases are examples of, should we be worried if you don't have a clinician in the loop? And I think the answer is yes, we should be worried. Let's take, for example, Utah. Like, that's what's happening there. I think as a primary care physician, I think it's very exciting to offer opportunities for patients who would normally have to wait 2 to 3 weeks to see a physician and then get a refill, right? That kind of 2 to 3 weeks can make a huge difference, right? Especially if you have to drive out from a rural area, et cetera. But if you don't have a clinician actually looking into whether or not this prescription should be represcribed, or if the AI makes some sort of dosage error and no one's looking at it, that is a scary world to live in.
Yeah.
Perhaps 10, maybe 5 years in the future, AI would be so super intelligent that we don't need it, but we're certainly not there yet.
Yeah. So that's an interesting point. So your overall take on an implementation like that is we're not there yet.
Absolutely. Clinicians need to be in the loop somehow, somewhere.
You know, in a previous time, worked a little bit with VC, with venture capital. So what do you think is the value add for a physician or a different type of clinician in bringing their clinical perspective to VC?
Yeah, so there's some basic things that a clinician offers, which is a clinical perspective, like understanding the literature to a certain degree, understanding the impact on patients. But the biggest thing that I think clinicians offer is a workflow perspective. For example, if you say, hey, my newest product here is going to save, a clinic 20 minutes because it's a faster way to run labs, right? Many clinics don't even have labs in their building, right? Sometimes they go to Quest or LabCorp, et cetera. And how big is this thing? Is there enough cabinet space in your clinic to actually put it up? So those kinds of very simple yet obvious things for us is not necessarily always thought about. But also that kind of clinical perspective is always something that I think venture firms are looking for.
We have a lot of founders who watch the show. So if you had a founder here or a product development team here, as an informaticist, as a physician, what is one thing that you would like them to watch this and take away from?
So if you are building something in healthcare, it absolutely helps to have someone who is in that clinical specialty or that space with you for a couple of reasons. One, to offer that kind of experience of hey, I've done this, so I can speak about this authoritatively. That gives credence to when you're trying to sell your product, right? So a healthcare system buying something or investing in a OB service, if you don't have anyone who is in that specialty, it's not going to look great, right? So that's one thing. And then two, you need something that you need clinicians for different perspectives. You don't need just someone for the workflow. You need someone who understands the medicine necessarily, and someone has connections. Every physician, especially in a smaller specialty, they might know each other. So it's definitely helpful to have someone like that on your team. Yeah,
I love that there's, Graham Walker, Dr. Walker, he was moderating a session on Monday, and he said, we cannot lump all physicians or all APPs or all nurses together in one, clinical care lump. And I mean, that's huge. Yeah. And I think even more so out of ED versus primary care versus hospital medicine, somebody who has worked in X, Y, or Z field within health tech. And so different clinicians, through their experience and their background and their education, can fill different roles for teams or with teams. So I think that's a great point.
At different stages.
Yeah, at different stages. I love that. All right. So you're here in the health tech hot seat.
Yes.
What is one AI hype that you are calling BS on?
Oh my gosh, this is such a good question, and I wish I had more time to think about it. Digital twins, I don't know if that works necessarily, but
I went to a talk today on the digital twin, and it was really interesting because it brought up who the heck owns the twin?
Oh yeah.
And it should be the patient.
Does the patient own anything?
The patient doesn't own anything.
Well, right now, who owns their own data? It's not the patient.
So if we build the digital twin, so that's an AI hype that we'll call on together. The digital twin is a great idea, but I don't think we have the infrastructure to deliver that. Or we're just going to have massive organizations that own your digital twin. And do we even want that?
Yeah.
I don't think I want that.
That's good.
I
don't want to steal that.
No,
think
no,
that's
no. You
something
can you can borrow it.
No, I don't want to borrow it.
Well, then what's one AI hype that you are like all in on? You think it's legit? You think it's real? You think it's
I
happening?
think AI scribes are real.
Really?
I think AI scribes are absolutely real.
But the ROI, 5 minutes for one encounter, you think it's
Depending on who. Like, I'm talking about a clinician's perspective.
sure?
I think it's very real for me. But I think there are a couple of add-ons that are making it more financially lucrative for healthcare systems,
Sure.
which is the RCM component. They're
Yeah.
building that in, right?
Yeah, yeah.
Um,
So kind of that's interesting. I know we've talked about like ROI. Can you piggyback off of other, implementations to, right? Because we talk about like within health systems, you have certain service lines that make money and you have certain service lines that don't make money. But you need both to adequately take care of patients. So, instead of focusing on all solutions as revenue generating or revenue saving, revenue capturing,
yeah.
can we buddy them up together? Like there's value in it some way, but maybe it doesn't, save too many percentages of whatever your bottom line is, but can you partner that tech with something else that does more, right?
Yeah.
I wonder.
I mean, that's how healthcare systems function. Things
Yeah.
like the surgery is paying for primary care,
Yeah.
essentially.
It was so great to be with you. This is the HealthTech Hot Seat. We'll see you guys later.